Hello everyone, I'm Dr. Su Siu Chu, consultant pediatrician and pediatric respiratory physician. Asthma in general is characterized by chronic airway inflammation with respiratory symptoms of cough, chest tightness, shortness of breath, or wheeze that vary in time and in intensity. The major difference between childhood and adult onset asthma, other than the age of onset, is the phenotype. Majority of childhood asthma is of the allergic disease phenotype, which is associated with personal or family history of allergic disease like eczema, allergic rhinitis, food or drug allergy, and responds well to inhaled corticosteroids. Common cold symptoms usually involve nasal congestion, runny nose, sneezing, and a mild cough without wheezing or shortness of breath. Allergies usually involve nasal congestion, nasal itchiness, sneezing, itchy or watery eyes, and a postnasal drip. And again, no wheezing or shortness of breath unless an asthma attack is triggered. An asthma attack usually consists of wheeze, persistent coughing, especially at night, shortness of breath, chest tightness, or difficulty in breathing, especially with triggers or viral infections or after physical activity. Making the diagnosis of asthma in children is based on identifying characteristic patterns of respiratory symptoms such as cough, wheeze, chest tightness, or shortness of breath, and documenting variable expiratory airflow limitation. For school-going children, tests that assess lung function include spirometry, which is available in healthcare centers with respiratory labs, or simple peak flow measurements, which are available in most healthcare centers. An improvement in either spirometry or peak flow measurements after a reliever medication, or an improvement in lung function 4 weeks after starting treatment, or variation in lung function between clinic visits are important and suggestive of diagnosis of asthma. For younger children that can't perform a lung function, we can monitor for symptom improvement after starting treatment or variability in the symptoms between clinic visits. And again, these are supportive of diagnosis of asthma. Other supportive tests include an allergy test, such as skin prick test, or specific blood tests for specific antibodies for common allergens like pet dander, mold, or dust mites. Asthma treatment consists of medication for control and relief symptoms as well as non-medication strategies. Controller medications include inhaled corticosteroids or oral anti-leukotriene medications to reduce airway inflammation. Reliever medications are inhalers that act quickly on the muscles that surround the airway to relax the airway and open up the airway and provide quick relief within minutes. The controller medications are stepped up or down in a stepwise manner according to the control of symptoms. Non-medication strategies include trigger avoidance, such as smoking cessation for parents who smoke, improved awareness, and healthy lifestyle with healthy diet and exercise. There are several common misconceptions about childhood asthma among Malaysian parents as well as parents from other regions. The first common misconception is that asthma is just a cough and cold that will go away. In reality, asthma is a chronic condition that requires long-term treatment and not just a passing illness. A cold can trigger asthma, but asthma itself needs preventive treatment with inhalers or oral medication to control the airway inflammation and prevent attacks. The second common misconception is that asthma drugs are harmful and can stunt growth. Although effects of inhaled corticosteroids on growth velocity are seen in young prepubertal children in the first 1 to 2 years of treatment, this is not progressive and not accumulative. One study that examined long-term effects showed only a 0.7% reduction in final adult height. Say the child is supposed to be 180 cm, that means there's only a difference of 1.2 centimeter. Whereas if the child has poorly controlled asthma with persistent or recurrent respiratory symptoms, recurrent exacerbations, frequent use of oral corticosteroids, they will have more detrimental effect on the height and the growth. And the last common misconception is that the child will outgrow asthma. While it is true that asthma may go into remission, it is important to note that remission is not a cure. As once a child goes into remission in childhood and adolescence, asthma may recur in later life. My advice to all parents out there is to pay attention to your child. Know their symptoms, listen to them. If they have persistent or recurrent respiratory symptoms, especially with triggers or after physical activity, if they are avoiding playing sports, please talk to them, find out why they may have asthma, and book an appointment with your pediatrician.